Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
So I'll just kind of briefly go over just our process that we've been doing at Madison Clinic, at Harborview, trying to implement the long-acting injectables. It's been a little bit of a journey in the last year or so, and hopefully also hear about you guys, who's actually been able to do it, any challenges or issues, and hopefully kind of help each other to kind of get through this process and try to get access to our patients this option of HIV treatment. So I have no conflicts or interest, and then our disclaimer as well. So just kind of as a reminder, the long-acting injectable with cabotegravir-rilpivirine is a combination of two different antiretrovirals, so integrase inhibitor that has cabotegravir and non-nucleoside reverse transcriptase inhibitor rilpivirine. And so it is indicated right now for patients who are 12 or older with at least 35 kilos, and it is to replace their current regimen, so not for treatment naive, and they also must be virologically suppressed on their current regimen as well. So that's kind of an important factor, just kind of looking at when we're considering starting treatment for patients for this. So the dosing injection schedule can be either monthly or every 2 months. So we've had kind of this shared decision making with patients about what might be better options for them. And it is an injection that has to be administered by a healthcare provider. So that's another factor of, are they able to come into clinic? So the oral lead-in is now considered optional, so can consider and discuss with patients, and they'll supply up to a month's supply of the oral form of the cabotegravir and rilpivirine. So this is just a general refresher just about the dosing for the injectable. So if you're doing the monthly injection, the initiation dose is the higher dose volume, and then the continuation is the lower. And then every 2 month schedule, you kind of have a 2-month loading in initiation period. So you do monthly injections for 2 months and then every 2 months after that. So just kind of thinking about how do we implement Cabenuva and what kind of considerations we have gone through in the past year. So I think the first thing is to really just kind of sit down with the patient and just discuss like the pluses and minuses, pros and cons of doing the injection if the treatment is really optimal, and then kind of review with them in terms of just clinically, are they eligible? So kind of thinking about, are they well controlled on their current regimen? And also just kind of thinking of like, what is the reason that they want to change to an injectable formulation of treatment? So I think everybody has different reasons and benefit that they might have. And then the other aspects of it, I think can be challenging, kind of thinking about insurance coverage, and then how are you going to acquire the medication? So that's actually a big aspect of the process as well. And then just the other kind of things to think about when you're doing the preparation and administration of the injections and adherence monitoring as well. So just kind of thinking about, shared decision making, I think it's important that we kind of go through with them before we kind of move on to the other steps to kind of think about when we do treatment. So, making sure that reviewing with them what is the current approved indication and, process for getting injectable cabotegravir-rilpivirine, and that it is 2 gluteal injections per dose. So you're getting each injection per medication, and that it is something that they must come into clinic or a facility that they can do injections. So I think that is really important as well. The other thing is just kind of going through their history in our charting, kind of when we do our eligibility requirement, just kind of do a full history, try to get as much of their history, HIV history as possible. There are some old genotypes out there that we kind of haven't looked at in a while. So just kind of getting those information, talking to the patient about their history. Did it actually fail, or were some of the regimen changes really related to side effects or drug interactions or other considerations why the regimens, were no longer used or changed? And then making sure you're checking for Hep B immunity eligibility, and then just kind of looking at their office visit history. Are they pretty good about coming in general? Or, are they refilling their medications on a regular basis? Those are not really absolute, but I think those are always good clues to help us to kind of see, how adherent they may be able to have with the injectables. And then also kind of looking at all their comorbidities, a lot of the times thinking about drug interactions, if they're on, antipsychotic medications or other drug interactions to consider about, like if they're on TB treatments and things like that. And then also their BMI, that's something that we've been kind of looking at as well. I think the most challenging part for us at Madison Clinic was really trying to figure out the financial clearance aspect of it. So who's going to do the benefits investigation about their coverage and where to submit the prior authorization. So I think that's the challenge. And I think depending on where you are at and what resources that you have, you kind of have a couple of options. At our institution, we decided to kind of go with utilizing some resources that we had in our pharmacy department that can do financial clearance for a lot of other medications like injections and infusions that they already do in other clinics. So we were able to leverage and request to kind of get some support there that they'll do the benefits investigations and prior authorization for us. If that's not something that you're able to get support from and you have limited support staff, then it might be a good idea to enroll in the ViiV Connect on their website, and then they have kind of slew of support to be able to provide, for them to do the benefits investigations and then hopefully kind of hold your hand to go through the prior authorization process. And then if they also need copay cards and those type of things as well, then they're also a resource as well. So it's not required to enroll, but I think if you need some of that support, that's going to be really helpful to kind of move that process along. And hopefully, if you're not really versed in it, even for me, it's not always easy. So having someone else to kind of hold your hands and get through that process just makes things a little bit easier as well. So the other aspect of it to really consider is like looking at your institution and where you are at, like how will you get the medication? So there are a couple of different ways that you can have access to the medications. The two main really ways that we kind of think about is what they kind of label as buy and bill. So buy and bill is the facility purchases the drug from our supplier, and then when we bill for the visit and injections, we submit it for reimbursement. And so at Harborview at University of Washington, we have a pretty big inpatient infusion, inpatient pharmacy. So we're able to kind of order this medications and have it on stock. We have like a limited stock. So they really do watch us looking at how many patients that we're actively treating, and then try not to over order, but have to have at least minimum, number of vials or kits on stock. The other option is that if you don't have a facility that can support something like that, or maybe the process of getting the medications on stock or P&T approval might be challenging, then maybe have to consider doing what we call like white bagging or specialty pharmacy kind of utilization. So it's kind of the similar thing of any other prescription kind of, where the provider sends a prescription to an in-network specialty pharmacy, and there's like a list of pharmacies that will have these medications in stock. Not all specialty pharmacies will, so only some. So it is available on their website, but also some of them might really depend on the pharmacy that's contracted with their insurance. So that's the other aspect of getting that benefits review and information might be helpful to know where to send the prescription as well. And then what the facility has to do is coordinate with the pharmacy to have it shipped to them, to the doctor's office or the facility directly, and not have it sent to the patient, since it does have to be administered in clinic. So that's why it's called white bagging, because it doesn't really touch the hands of patient. You're getting directly from a pharmacy source to the medical office. So, there is cold chain, thinking about temperature, these are refrigerated items. So there's no kind of mystery or issues with that. But then if you are having this process, then it is important to kind of make sure that your EHR, your billing in terms of administration, that is only like submitting for the injection administration versus the actual drug. So just making sure that you're working with your institution on that aspect of it. And then finally, if you are opting in to do the oral lead-in treatment, you can submit it through the ViiV Connect enrollment form, or because we weren't enrolling our patients in the ViiV Connect, you can actually send prescriptions directly to Theracom Specialty Pharmacy. So that's the only pharmacy contracted with ViiV to supply the oral lead-in. And so you can actually send it to them on a prescription. They usually call you, verify, all the patient's information, and then they kind of send it to you pretty fairly quickly as long as you confirm, since there's no insurance involved. And they just want to know that you've got the injection approved by their insurance, so that we're not just sending oral lead-in and then they're not going to be able to start the injection. So that's been pretty easy in terms of that. So the kits come in 2 different kit boxes. So the higher dose, the 3 ml kit, is for the either every 2 month or the initiation dose when we're doing monthly injections. And then the 2 ml kit is the continuation dose for every monthly injection dose. So just keeping in mind that if you're doing monthly, then you do need to supply 2 different kits on site. But if you're doing only every 2 months, then you only have to worry about supplying the 3 ml kits. The kits do come with syringes, vial adapters, needles. Unfortunately, they only have the 1.5-inch needles for injection. So for patients who have a higher BMI, so if their BMI is over 30, they do recommend to consider using a longer needle, like 2-inch needles, but you do have to provide that in the clinic. So hopefully that you guys have that in stock. If that's the case, usually we're looking at that more in terms of if you're already stocking some of those needles already. But when we're starting and scheduling injections, we're kind of looking at that and making sure that we have those in stock before the patient comes in. The kits have to be stored in a refrigerator. So the storage is actually pretty strict. As soon as they're removed from storage, and then you usually pretty much have to commit to doing the injection, or it has to be wasted. Obviously, brief moments of removing or moving to place is probably reasonable. But even when I had talked to the rep and the support staff there, they were pretty much like, try to minimize as much time as possible of having it outside of the refrigerator, and then so that way it doesn't get wasted. And so the administration wise, just we're reviewing with the patient, 2 injections for the complete dose. And then the vials, once they move it from the kit and the vials, you have to kind of let it warm up, for 15 minutes before at room temperature before drying up on the syringes. They are suspension, so you kind of have to let it resuspend. And so we're talking about the storage, is that if the vials are good at room temperature for up to 6 hours, but must be discarded if not used. And if you have drawn up the dose in the syringes, they're only good up to 2 hours, so must be discarded if not used. So just being really careful about making sure that the injections is going to happen before they were removed from the fridge or drawn up. And then usually, because they're 2 separate gluteal injection sites, either you can do separate areas completely, but at least 2 centimeters apart. And then the recommendation is to, due to potential post-injection reaction, patients should be observed for like 10 minutes after the injection. So I highly recommend, and just so that we're tracking, and in our clinic, we do have a lot of patients. And so it's probably a good idea once they get their injection that you schedule their next one in time, and kind of identifying the target dose dates. So I usually write in there like their target date is 1 month or 2 months from whenever they're due. And then I actually put the range of 7 days before or 7 days after in kind of my charting, just so that way we're not trying to recalculate later, but we already have that information. So it's easily accessible. And we've been recommending to do like 4 weeks or 8 week, like weekly schedules versus like 1 month or whatnot, because if it falls on a Saturday, then you have to reschedule or configure. So I feel like it's easier that if they come on a Friday, they always come on a Friday, just to kind of keep things as consistent, as easy as possible for the patient as well. So I think having someone who can track and when they're due and when they're scheduled for injections, and then also just to make sure that we're coordinating, we have the medication supply when they're scheduled to come in, and then also tracking their prior authorization. So what we've come across is that some of the insurances will only approve for like 3 months, and then some of them say that they don't need our requirements, but then we don't know what happens next injection. So it is really good to kind of keep up and have someone kind of looking at that before they come in so that we're not having any issues at the back end. So I think generally just talk about some of the things that I've learned so far working in our clinic and working with our staff here. I think it's really important that when they're coming in for the injections that you really verify. We worry about kind of wasting medications if they change their mind their last minute. I did have a patient they were scheduled, but then after taking the oral lead-in, like on the day of, they were like, you know what, I thought I could see if it would get better after overtime, but it just didn't. So on the day of the injection, they changed their mind. And so just kind of making sure, and at every point, the patients, they definitely have the wherewithal of deciding if they want to continue with the injections. And so they can stop at any time and change over. So I think those are good conversations to have and just having that good communication. And I think right now at Madison, we only have 3 patients that they've actually received 2 doses so far. So, and all of them been doing well. And no issues so far. I did have someone kind of complain that rilpivirine is particularly more viscous, and the nurses, have reported that like the injection has to be a lot slower than the cabotegravir. So that's to kind of keep in mind. So I have a couple of those patients who were like, I noticed one is worse than the other. So just keeping that in mind in terms of that. And then in terms of getting the prior authorization, so in Washington state, the Medicaid plans have been really, really specific about documenting that they're receiving the oral lead-in. So we've been kind of documenting that we will start it, but only when the injection is approved. So we're not having to coordinate that before, if it's not approved anyway. And the other thing that they've kind of had issues regarding is like making sure that the patient can't take oral medication. So they've been kind of strict so far about that. We've had actually several denials because they were like, this seems like a person who can take pills every day. So we've gotten some rejections on the treatment, unfortunately. So just kind of making sure that you document if they're having any issues, whether it's physical or psychological or something, maybe stress or anything that can kind of, you feel like is, important for them to know that maybe doing the injection is beneficial for the patient. And the plans have been all over the place, whether they require the buy and bill or specialty pharmacy. So, and some of them are both. So I think just making sure that you're clear on how you're submitting the prior authorization or what your institution is wanting to prefer. So that way you're not submitting it to somewhere and that's not what the approval was for. And especially because if you're doing the buy and bill, you're submitting it to the medical plan, not the prescription plan. Sometimes the prior authorization can take quite some time. We've had at least like 10 or 15 business days for actually even an initial response or any kind of update. So just kind of thinking about that, just kind of putting a perspective for the patient and just expectation of like, some of them, it may take a little bit longer than other. And I mentioned earlier about tracking the prior authorization, like we have someone, they only approved 3 injections and we have to resubmit the viral load to continue on. So we're tracking those expiration dates and then resubmitting it in time so that they can get their next injection. So I think those are things to consider. And also thinking about the out-of-pocket costs for like, even if it's prior authorization, if it's a higher tier, or they might have a high out-of-pocket cost like copays. So thinking about those through before, we're committing, or if the patient, making sure that they feel comfortable with that, or providing additional support for any financial support for those so that they don't have like a huge bill or surprise when they get the injection. The other thing that we've kind of come across, our institution, we have we're doing the buy and bill process, just because we do, in our institution, we do have a policy that we can't do a white bagging, so we can't have medication coming from somewhere else. So it's good to check in if you're especially a bigger institution, that if there's any policy of those things, that making sure that you're in line with that, and then kind of working with your institution, making sure that, those, that the process is going to work for all parties involved. And I mentioned earlier, the oral lead-in, it comes fairly quick. So that is the easiest process, I think, in the whole process for getting the injectables. And then if you are wanting to do the bridge therapy, so if they're having, scheduled missed doses of travel because due to travel or other issues, the Theracom pharmacy, they will only provide the cabotegravir. So the rilpivirine has to be supplied through their regular retail pharmacy. So just kind of keeping that in mind if that's the step that you're taking. But I think overall, it took a lot of process to kind of build this and learn and kind of trial and error during so far. And we still have quite a few patients that we're kind of screening through and going through and trying to get them, go through the injection process. And I mean, definitely it's going to be increased workload. I mean, right now we only have, a few patients that we're doing, the injections continuously, but as we kind of go through our requests and referrals, that there's quite a few. So that's really implementing how the nursing, and these days, depending on the the cases and pandemic, it's just up and down on how things are going with that. So I think it's having that process laid out a little bit earlier in the process, so that way things are smooth and you have kind of a backup plan who's going to cover what.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.